So we're going to talk today about different things that can cause hip and groin pain. The hip is a particular region that so many other things other than a neuromusculoskeletal cause can be resulting in hip pain. So we need to talk about those today and other things that can mimic and appear to be neuromusculoskeletal problems. We have to look at the joints. So the lumbar spine, the SI joint, and the knee all can refer pain to the hip. Again, how we differentiate those is if the hip pain is coming from the lumbar spine, then the hip pain will be made worse by lumbar spine movements. SI problems frequently refer pain to the hip. SI problems are more common in females, particularly young females, or females having generally, because of childbirth, having a more flexible pelvis, more subjected to hypermobility and instability issues. So hip pain is a very common problem, but again, the hip pain is created by the SI movement, not by the hip. And similarly, the knee can refer to the hip, but it's the knee movements that therefore reproduce a patient's hip pain. There are also other neuromusculoskeletal causes of hip and groin pain. So if we look at neural, the nervous system, centrally we see that any from thoracic spine, the 12th thoracic spine, to the lumbar third level, and shape from 3-4, all can refer pain to the hip and groin area. So that's a central cause. Again, that would be segmental dermatomal pain. So any of those segments can refer pain to the dermatomes, which encompass the hip and groin. So you can see that's a pretty wide area. At a more peripheral level, we have the obturator nerve, which can very much mimic an adductor tendinopathy, iliohypogastric and ilioinguinal nerves, and the genital branch of the genital femoral nerve. And those nerves actually become important with things like abdominal surgery, with weight gain, with tight pants, and a pregnancy can all affect those peripheral nerves, resulting in hip and groin pain. We also have bony injuries, so we can have fractures, avulsion fractures, which are more common in adolescents. We can have stress fractures in this area, dislocations, and then, of course, we'll talk later on about the childhood diseases such as congenital hip dysplasia, Legg-Calvé-Perthes disease, slip capital femoral epiphysis, and also OA, whether it's primary or secondary arthritis. The hip is a favorite area for osteoarthritic change. We also have muscular causes of hip and groin pain, whether a strain being grade 1, 2, or 3 injury, with grade 1 being just a few micro fibers torn, right up to a grade 3 tear, which is a complete tear. We're going to talk about contusions. We're going to talk about tendinopathy versus tendinitis versus tendinosis. So tendinopathy is simply pathology of the tendon. Tendinitis is inflammation, and tendinosis is breakdown or degeneration of the tendon. Around the hip, there are also many bursa: the iliopectineal anteriorly, the trochanteric laterally, and the ischial, which is what you're sitting on, bursa, all can mimic and create hip and groin pain. Again, bursa, the acute bursa, anywhere in the body, do not follow the theory of selective tissue tension testing, but chronic do. So these are overuse, friction, injuries, causing irritation. And again, the problem with bursa is they can become infected. We also have to consider that there are many non-neuromusculoskeletal causes of hip and groin pain. So we need to look at causes that come from the GI system, causes that come from the vascular system, the inflammatory, lymphatic, urological, testicular, or gynecological, and oncological. And we're going to talk specifically about things under each of those headings that can create hip and groin pain that are not within our scope of practice and that are requiring immediate referral back to the physician for any of these other findings. So again, when we talk about gastrointestinal causes, one of the most common is hernia. And certainly of the hernias, the most common is the inguinal hernia, which is more common in males. And then there's also a femoral hernia, which is more common in females. But hernias develop as a result of a congenital weakness in the lining of the abdominal muscles and fascia, and they cause sort of an aching groin pain and often a small tender mass. So the patient will often describe coughing or sneezing or bearing down that increases the size of the bulge due to the increase in the intra-abdominal pressure. So this can actually mimic chronic muscle and tendon injuries in this area. But the pain can be increased by rotation or hyperextension of the hip or spine, or often they describe it with quick changes in direction. Appendix is another GI problem. So this is, again, the appendix related to the small intestine. The appendix relating to the intestines. So one of the often areas that patients describe with this is McBurney's point. McBurney's point is assessed with the patient supine, and it's the halfway point between the umbilicus, the belly button, and the ASIS. So this is a point, McBurney's point is a point that of maximum tenderness and pressure in this area can elicit the patient's pain. As you can see from this diagram, pain into the right hip groin area is a very common referral, and the patient may not actually have abdominal tenderness. They may not have nausea, vomiting, fever, all the other things that tend to go with appendix problems. When we look at vascular causes of hip and groin pain, one of the ones that we need to consider is hemophilia. Hemophilia is a blood disorder that can cause bleeding, particularly into the iliopsoas muscle or into the wall of the large intestine. And this certainly can result in pain and spasm of the iliopsoas muscle. So as the blood pools, then the pain increases and intensifies. The other things associated with that then would include fever, bloody, tarry stool, perhaps emesis, so when they throw up blood. There may also be pain on active and passive and resisted hip flexion. So this is not following the theory of selective tissue tension, and that's because of the spasm in the iliopsoas muscle. There may also be swelling or warmth or spasm, palpable spasm in this area. Another vascular cause of hip and groin pain is an abdominal aortic aneurysm. And this often creates mid-lumbar and lumbar spine, usually first, but certainly it can go into the groin. The bifurcation of the aorta is actually at the level of the umbilicus, so it can certainly cause pain in that area. The pain is not, so this is what differentiates it from the hip and back. It's not made worse by bending or stooping or sitting or lifting. Sometimes they'll have pain with symptoms that include cough. So other symptoms, coughing or shortness of breath or hoarseness. It's more often seen in males, usually over the age of 50, and often they're usually of poor health. So they often have a history of high blood pressure or previous stroke or transient ischemic attack or arterial sclerosis. And with these, the patient often describes a pulsating mass. So they'll say, I put my hand here just below my belly button or to the right or left of my belly button. I can feel my pulse. And certainly you may actually feel this mass. You may feel the pulsating mass. And if you check the peripheral pulses, you would in fact find that the pulses were diminished. Another vascular cause of hip and groin pain is vascular necrosis, which is the loss of blood supply to the head of the femur. Certainly it's most commonly caused by fracture or dislocation, or certainly a total hip joint replacement will sever the blood supply, and it can also be the reason why the severed blood supply, why a total hip joint replacement is needed. It can result from alcohol abuse, or sickle cell anemia, which is more common in Afro-American individuals. So the pain is into the groin and thigh, and the pain is actually from a blockage of the blood supply to the femoral head, so particularly the obturator artery. And this artery travels with ligamentum teres and can be damaged then with fractures and dislocation. The thing that's most important about avascular necrosis is it needs to be suspected when there is a history of dislocation or fracture in this area, because it often doesn't show up for 6 to 8 weeks, although the patient may experience progressive difficulty when they should be getting better. After 2 to 3, 4 weeks, that they're having more and more difficulty and more pain with weight bearing. And often after dislocation and fracture, they're not seeing the surgeon again for 6 to 8 weeks, although they're coming to physio. So we need to be suspecting that if a patient has been progressing and then all of a sudden starts to have more trouble with gait, more trouble with weight bearing, more pain following a fracture, following a dislocation, we need to be suspecting that this could be avascular necrosis, and that if something isn't done about it immediately, ultimately they could end up needing a total hip replacement because of the loss of blood supply. So one, we need to recognize this condition. 2, we need to get them back to see the surgeon for follow-up. So an X-ray or an MRI can pick this up. And again, from that standpoint, what the surgeon can do is they can do what's called cord decompression, which is a drill into the femoral head. They drill literally till they hit blood to try and restore blood supply to the femoral head. And that can prevent the head of the femur from dying. If that's unsuccessful, unfortunately, a total hip joint replacement is often needed. With inflammatory diseases that can cause hip pain, probably the most common is psoas abscess, and that can result from Crohn's disease, which is now called irritable bowel disease. I'm not quite sure. They switched to irritable bowel disease from Crohn's because it was felt that patients were being stigmatized because of the term Crohn's disease. Forgive me, I'm not quite sure, but irritable bowel disease or irritable bowel syndrome to me sounds more stigmatizing than Crohn's disease, but that's just my personal opinion. So appendicitis can also cause a psoas abscess, as can pelvic inflammatory disease. So with the psoas abscess, what's important is it's an insidious onset of hip pain and pain sort of in the medial thigh and the femoral triangle area. So the abscess is actually a collection of pus or infection. And so it can result from any inflammatory process that involves the peritoneum. And the pain is made worse by both active and passive and resisted hip flexion and external rotation. And then the stretch in the opposite direction is also painful. So with passive hip extension and medial rotation, it's painful. The problem with the psoas abscess, one of the problems that can develop as a result is hip flexion contracture if it's a long-standing problem. Ascites is an accumulation of fluid in the peritoneal cavity. It's often associated with chronic liver disease and alcohol abuse. And it can also result in insidious onset of groin and low back pain. These patients are often very, very sick. What you would see is a distended abdomen, and then you also have very, very swollen ankles. So this is someone you're more likely to see in a hospital situation, not generally in an outpatient clinic situation. One of the other inflammatory diseases we need to consider is septic arthritis, which is arthritic problem caused by infection. So from our consideration there is we need to know, is there any history of recent surgery? Is there any history of recent inoculation, even any dental surgery or dental work? Because this is an infection that enters the body, and often from a foreign source and foreign destination, and enters the body, say from a root canal or from an inoculation, and targets the weak area, which in this case is the hip. So it produces hip and groin pain, and it's systemic, so it affects multiple systems. So the patient may also complain of like fever or loss of appetite, and the hip would be warm and swollen and held in flexion. So this is actually most common probably in children, age 1 to 2. And as I said, there is often a history of infection or surgery or some sort of recent trauma. What is important also to recognize with lymphatic causes is that, so lymphatic disease causes enlarged lymph nodes or lymphedema in the groin area, and this is relatively uncommon, but it's one that we need to really be aware of. So if it is painful, certainly infection and sexually transmitted diseases are certainly capable of generating a painful and large lymph node in this area, so right along the and below the inguinal ligament. Hodgkin's or non-Hodgkin's lymphoma are cancers of the lymph system, and they tend to be associated with non-painful lumps in this area. Our concern always with infection or with possible cancers, there may be a history of fever or chills or discharge as well. So certainly if the lymph nodes are enlarged in more than one area and persist for longer than a month, whether they're painful or non-painful, they require medical referral. Non-painful lymph nodes that have been present for longer than a month are perhaps our more serious concern, just because of the high risk of being associated with cancer. So then again, Hodgkin's or non-Hodgkin's lymphoma being the most common. So non-tender lymph nodes are usually the more sinister, but certainly infection and sexually transmitted disease are certainly treatable things and need to be addressed quickly. So if a patient's telling you they've had a painful lump or a lump that's been present longer than a month, it needs to be followed up. When we look at urological causes, there's a lot of things that can cause related to the kidneys and ureters. So they often have not only hip and groin pain, but symptoms of nausea or vomiting, or that their bowels don't move as well. The pain is not affected by change of position or movements of the spine. So let's start with ureteral pain. It usually starts at the rib spine angle and radiates into the lower abdomen and groin genitalia area. And it's the most common cause of kidney stones are the most common cause then of ureteral disease. And the kidney stone can actually distend and block the ureter, and that results in pain and spasm until the kidney stone can be passed. And so when the stone moves down the ureters, it creates waves of renal colic, which is just excruciating and supposedly the most painful experience a human can have. Renal pain, so related to the kidneys, is often unilateral, and it's felt as, again, an achy pain, often described as flank pain, and it also may radiate into the abdomen and lower quadrant hip area. As well, we can have prostatitis. Again, it can be acute or chronic. It can mimic a partial tear or tendinopathy of the adductor longus. So this is mainly in males that are over the age of 30. It can happen younger, but it's usually older males, and usually an insidious onset, which is, again, pain worse with voiding, and there may also be a discharge noted with that. They may also have fever, chills, just not feel well, frequency of urination at night. They may also report changes in bowels. Urinary tract infections, certainly they also can present as groin pain. So in that case, there's a burning sensation with voiding. And again, they can have fever or chills, or maybe itching. Again, it could be related to poor hydration. And really, the symptoms depend on the part of the urinary tract that is affected. Certainly, lower tract urinary infections are more likely to cause pain into the groin area. Just wanted to show you these. These are what are called staghorn kidney stones. So look at the size of this. So this is, staghorn. So this is in the ureter. So it's left the kidney. It's in the ureter, and you can appreciate we're looking at almost 5 centimeters, 2.5 inches. size. So needless to say, the patient could not pass these. They had to be surgically removed. I think you can understand how painful that would certainly be in trying, even attempting to pass these kidney stones. We also, particularly with males, need to be concerned about testicular causes of hip and groin pain. So testicular torsion or rupture is usually from direct trauma, and we can all appreciate when we see someone get hit in the groin, males probably more so than females, but the pain associated with that. But this is actually a medical emergency that needs to be dealt with. In this case, the venous or arterial blood flow may be insufficient, and so the groin pain is extremely severe. And again, this needs to be dealt with immediately, otherwise the male may be rendered impotent. So again, there may be swelling, there may be vomiting, nausea, and again, following trauma to this area. Epididymitis is an acute swelling of the scrotum, and again, most often seen in teens and young adults, but in this case, more related to sexually transmitted diseases. So again, this patient would present with extreme tenderness over the upper aspect of the testes, but more not related from trauma. Cancer of the prostate is the most common cause of cancer in males, particularly over the age of 50, and the risk actually increases with age. So the common presentation is a hard, painless mass on the testes. Hydrocele is a fluid-filled sac that forms along the spermatic cord. So it's actually caused by the inflammation of epididymis or testis, and or by lymphatic or venous obstruction of the spermatic cord. So the pain is usually localized to the lower spermatic cord region. Blunt trauma certainly can rupture or dilate the plexus of veins that are in that area around the spermatic cord. And this is referred to as a varicocele, which is a soft, painful, rubbery, elongated mass that forms around the spermatic cord, usually on the left. Again, the problem with this is that if it's not detected quickly, so it is requiring medical follow-up and urgency, is that it can result in infertility. Females also have their causes of hip and groin pain, so certainly an ectopic pregnancy, which is where the egg implants itself rather than in the uterus, but in the fallopian tube. Cysts could form in this area due to friction and rubbing. There can be a twisting, and that's what this bottom diagram is showing, a twisting of the ovary. There could be inflammation of the vagina, again from infection or from irritation. There could be a recent abortion. And this is one that you have to be very, very sensitive with your patient, especially with asking about abortion or sexual assault. Patients may be very reluctant to talk about those things. And so if there's any concern about that, you're going to have to preface why you're asking questions, for example, about the relationship of their, hip or groin pain to menses, or to sexual activities, or to use of intrauterine devices, for example, for birth control. So again, but all can certainly account for hip and groin area pain. These again are causes and require medical referral, things that are beyond our scope. We also have to consider oncological causes of hip and groin pain. So osteoid sarcomas, or osteoid osteomas, bone tumors, aneurysmal bone cysts, which is what is shown in this X-ray, spinal metastases, so bone pain that has metastasized from the lumbar spine, particularly to the hip, is a favorite target area. Chondrosarcoma, which is one of young adults that affects the cartilage, and giant cell tumor, Ewing's sarcoma, chondroblastoma. These are all tumors that affect the hip and groin pain. And What we're concerned most with here is recent weight loss, night pain, any pain that seems to be night pain that it seems to be affected by aspirin and controlled by aspirin. So those are the things that we're concerned about. Unremitting night pain, off the floor pain. Previous history, for in the case of spinal metastases, there's a history of previous cancer. So now all of a sudden the patient has been treated and now they're presenting to you with hip pain. That's always a concern. Could it be metastasized?
Nice. Whoa. You okay?
So we're going to start by talking about some of the traumatic hip injuries. The first thing that we need to have when we talk about hip injuries is what was the mechanism of injury? What was the position of the hip at the time of impact? Was the hip flexed? Was it internally or externally rotated? So in the case of car accidents, certainly they account for 70% of all hip dislocations. The position of the hip can dictate which way the hip will dislocate. For example, if the hip is flexed anywhere above 50 degrees and adducted and internally rotated, the hip is more likely to go out the back door, so dislocate posteriorly. But if the hip is abducted when it strikes the dashboard and externally rotated and flexed, it is more likely to dislocate anteriorly. So we need to understand the position of the hip. We need to understand the forces that are acting at the time of impact. So again, we can appreciate that contact in sports and what is happening. What was the mechanism of injury? What was the contact? And the same with football. There doesn't even have to be, just that pivoting and twisting. We know that a lot of the traumatic injuries happen as a result of violent contact or as a result of speed. So speed tends to result in twisting action. So we need to look at traumatic injuries from the standpoint of, how would we know? How would a pelvic fracture compare to a hip fracture compare to a dislocation? What do we know about those? We know that pelvic fractures are often caused by a direct blow. We know that hip fractures are often described as intracapsular or extracapsular. What's important about an intracapsular or garden-type fracture is that they're often caused by twisting and stumbling. So, for example, tripping on a floor mat. Usually in the elderly and usually in postmenopausal women. So definitely more common in females than males, and usually over the age of 70. So intracapsular fractures are the most common hip fracture. And the twisting often causes the fall, or causes the fracture, and the fracture causes the patient then to fall down. So the fall is actually secondary to the fracture. So it's the twisting action with abnormal bone that causes the fracture. So those are referred to as garden-type fractures 1 to 4, with 1 being incomplete and the least serious, and 4 being type 4 having complete and full displacement of the fracture. So that's certainly a concern. The extracapsular fracture is actually a better prognosis because this fracture then is outside the capsule, and the importance about the intracapsular fractures are the fractures that happen in the capsule are usually in the area of Ward's triangle. And Ward's triangle is an area of weakness in the trabecular bone patterns of the femur, in particular in the postmenopausal women. So this is an area where there's inherent anatomical weakness in the bone. So instead of having this vertical and horizontal and oblique trabecular bone structure in this area, but there's an area of inherent weakness where we don't have overlapping patterns. So in essence, it's the Achilles heel of the hip, so it's a weak bony area. The body tries to compensate by that, so it has an extra layer of connective tissue around this area, around the femoral neck, which is called the zona orbicularis. It orbits the neck, so it's like a dog collar of connective tissue. Unfortunately, though, that isn't as strong as bone, and so fracture happens in this area. When we look at extracapsular fractures, so again, these can be trochanteric, intertrochanteric, peritrochanteric, so fractures in between the trochanters or around the trochanters or below the trochanters. These are usually from a fall or a direct blow to the area, or they can also be muscle pull, so they could be avulsion. FS is a femoral shaft fracture, and it most commonly is a motor vehicle accident. If it fractures mid-shaft, certainly one of the concerns always is, could it be an osteosarcoma? So cancer. It is a pathological fracture. So mid-shaft fractures for no or minimally contact or twist are always a concern because it could be pathological bone that has caused the fracture. With regards to dislocation, so we know a lot about dislocations of the hip. We know, for example, that they really aren't that common. They only account for 5% of all the hip dislocations anywhere in the body. We do know that certainly they're far more common in males than females by 3 to 1. They're most common in the 16 to 40 age group. And they, again, usually involve the high-velocity sports, so skiing or football, or car accidents, which account for 70% of all hip dislocations. So 90% involve a posterior dislocation, so the hip going out the back door. And the mechanism of injury there is the knee is flexed, the hip is flexed greater than 50 degrees, it's adducted and internally rotated, so that at the time of the impact, the femur then is driven backwards, outwards, and upwards. And when it does that, a lot of times it shears off a piece of the acetabulum with it. So posterior dislocations are the most common, and they have all sorts of complications. So if it, in 50% of times when the head dislocates out the back door, it will actually fracture a piece of the posterior pillar of the acetabulum. And the problem with that is then osteoarthritis is likely to develop. It can fracture the femoral nerve. 10% of posterior dislocations injure the sciatic nerve. Certainly, it can cause avascular necrosis. So what the statistics say that 20% of all posterior dislocations develop avascular necrosis. So we need to be aware of that. So if our patients are developing trouble weight bearing, several weeks after a posterior dislocation, and they're not getting better, and they're having more and more pain with weight bearing, we need to send them back immediately. It's very common for osteoarthritis to develop secondary to dislocation. Myositis ossificans, which is the ossification of a hematoma that forms beneath the periosteum, between the periosteum and the capsule. If you dislocate, you can tear the ligamentum teres or the posterior capsule. You can tear the ischiofemoral ligament in a posterior dislocation. An anterior dislocation really only happens about 10% of the times, and it's most often a dashboard injury again, this time with the hip flex abducted, externally rotated. It can occur with a twisting away from a hyperextended hip, or it can occur with getting hit from behind while you're in a squat position. So the complications from an anterior dislocation are certainly, again, avascular necrosis, but not as common in anterior as posterior, only 4% accounting for avascular necrosis in anterior dislocations. Can certainly fracture the anterior pillar of the acetabular rim, and again, that can result in osteoarthritic change. Can injure the femoral nerve, or artery, or vein, anything that's in the femoral triangle. So the patient may actually present with color changes to the lower extremity. Can tear the ligamentum teres in the anterior inferior capsule, and also the iliofemoral and pubofemoral ligaments. When we look at pelvic fractures, certainly they can occur at any age, any gender. Avulsion fractures are certainly more common in adolescence, in which case they often describe feeling a pop at the time of injury. Intercapsular fractures are more common after the age of 70, again in females. Extracapsular fractures, again, more common in osteoporotic females, postmenopausal osteoporotic females. Femoral shaft fractures are more common in young adults, especially, again, the middle of the femur associated with cancer. dislocations are definitely teenagers and young adults involved in the high-speed sports. In all cases, the pain is going to be very localized to the fracture or to the soft tissue area of disruption. In the case of assessment, there is no assessment. If you suspect your patient has a pelvic fracture or a hip fracture or a hip dislocation, there is no assessment. It's immediate transport to emergency room, and again, you're maybe following them post-surgery or post rest and recovery, but there is no assessment. So in all cases, the x-rays will be diagnostic. What do we know about the anterior dislocation? So if somebody has dislocated anterior, could they walk into your clinic? Yes. So again, they would present with the hip that is unreduced, so it's still in the dislocated position, with the head anterior in the groin, the leg is shortened, it's externally rotated, it's flexed, and again, it needs to be medically reduced. So it is still caught in that top diagram. It's still caught, the top left and bottom left diagrams, in that anterior dislocated position. So those are rare. More commonly are the posterior dislocations. Again, shortening of the leg is actually held in the position it dislocated. So in this case, in the right diagram, is a young child, and the head is dislocated out. So this was a fall off a bike, dislocated out the back door, and the hip is fixed in internal rotation, flexion, adduction. So the thigh is actually resting on the other leg. So could we recognize someone who came into our clinic non-weight bearing with their hip fixed in that position? All right. We also need to talk about hip and pelvic fractures. So you can have isolated fractures. You can have, for example, 4 in the series of fracture of the iliac limb. So again, that could be a blow, something falling and landing and creating a vertical shear force. We could fracture the ischium. We can avulse a piece of bone. So we could avulse a SIS from pole sartorius. We could avulse AIIS, the anterior inferior iliac spine, from the pole of rectus femoris. So again, we need to look at all these types of fractures. These are considered, the fractures I just talked about are considered stable fractures. So then we need to talk about what are called open book fractures. An open book fracture is, again, considered a stable fracture, but it results in disruption of the pubic symphysis and tear of all the posterior ligaments, usually from a frontal impact. So my patient was a motorcyclist, and he went off his bike and straddled and hit a hydro pole, straddled. So you can appreciate the trauma to the genitalia, the trauma to the pelvis, but the pelvis literally opened up. So the symphysis separated, the posterior aspect of the joint is compressed. The good part about this fracture is that the fracture opens the pelvis, so it's often not as commonly going to affect the rectum, the bladder, injury, so causing other systemic problems. So again, this is a frontal impact. It's considered stable. It's referred to as an open book fracture. This is another another open book fracture, but this one is actually considered unstable. You can see the pelvis is separated both anteriorly, and you can see how it's crushed inwards. So the symphysis pubis is disrupted. Again, it's often associated with a fall from a height onto one leg, creating that vertical shear force, so it's unstable both front and back. And you can see how the pelvic rim is narrowed. And it can also result from a side impact, motor vehicle accident, so getting T-boned from the side. So the problem with this is, again, it can rupture the bladder or the urethra or the rectum because you can see the pelvis is being narrowed. The bony fragments can be driven into the pelvic area, resulting in other complications. This is, again, showing a pubic rami fracture. This was a patient who fell off a beam, straddled the beam, and again, you can appreciate the trauma involved with that. So when we look at fractures of the acetabulum, we need to start with the anterior pillar fracture, which is what this is showing. This is the one that results from commonly from an anterior hip dislocation. And from that standpoint, again, it is a fracture of the weight-bearing surface, so it can result in osteoarthritic change. The posterior pillar fracture is the one that's associated with a posterior dislocation. And again, you can see that the fracture goes through the weight-bearing surface, so osteoarthritic change is a problem. The other problem with this fracture is that it's not uncommon to injure the sciatic nerve posteriorly. This is called a composite fracture or central fracture. And again, the problem with this one is the very poor prognosis because the articular surface is actually damaged, and trying to put it back together again. So the head, this is often from side impact, the head is literally driven through the acetabulum and it shatters. So I talked about earlier Ward's triangle. So Ward's triangle is this area of the neck of the femur that you can see. So these are oblique bands, these are vertical trabecular structure, and these are arching, and horizontal fibers. But you can see in this area there's very little overlap of that trabecular structure. So you see down in the intertrochanteric region you've got vertical fibers, you've got the horizontal fibers, you've got oblique fibers. And same with the head, you've got overlapping, but look at the neck. There's only the arching oblique fibers. So this is an area of inherent weakness, and this is where the intracapsular fractures happen. So this is a displaced, so this would be a type 4 Garden fracture with the displaced head of the humerus, or head of the femur, excuse me. So this, again, is not someone who's likely to come into your clinic. However, a type 1 Garden fracture could be weight-bearing intelligent gait pattern. This person would not be weight-bearing. So how are they fixed? They're fixed with open reduction, internal fixation, and usually with screws. So these are called compression screws that go through the neck into the head. And again, they are usually, weight-bearing is tolerated for 6 to 8 weeks. Intracapsular fracture, so that you can see this is unreduced at this point in time. You can see the shortening, the hip is flexed and externally rotated. There's actually the overlap of the bone. Could you recognize this? Subtrochanteric or extracapsular fractures, so the subtrochanteric below, so this is actually a fracture below that trochanteric line. And again, this is better prognosis. This is a better area of blood supply, better trabecular structure, so the bone tends to heal better in this area. It's also more amenable to fixation. It's easier to get to. This is open reduction. This is called the plate and screw fixation. So this is a very large compression screw with the screws into the shaft of the femur. So this is called a compression screw into the head. And again, these screws, they look like they're crooked, but remember this is a two-dimensional x-ray. The intertrochanteric fracture is a fracture between the trochanters. It can be due to muscle pull. This is what it looks like on the bone. This is what it looks like on the x-ray. And again, this is an extracapsular fracture that tends to do pretty well if it heals. Now we need to talk about contusions and muscle strains. So contusions are a blow, caused by a blow to the area. So you can appreciate in hockey or in soccer or contact. So the mechanism of injury is some sort of direct contact. There's usually immediate pain that gradually improves with gentle activity. So they're eventually able to move and it starts to feel a little bit better. It may become a palpable lump, which can become quite hard. Gentle stretching may be bothersome, but at this point in time, usually there's no loss of strength unless there is pain, in which case then pain could inhibit function, muscle function. So there's often bruising, bleeding, ecchymosis, so bleeding into the soft tissue. In this case, the contusion was caused think you can guess by the pattern on the leg by a soccer ball. So pretty clear idea of what caused the bleeding into the soft tissue. Muscle strains, the mechanism is often non-contact and could be a violent muscle contraction. It could be eccentric overload. So again, the pain may be at the time, but they're usually able to keep going, but it's often that the next day or when they cool down that they really start to feel it. So, and with use, again, the bruising or swelling, because it's so much deeper, is often absent or delayed. And so this was a muscle strain, hamstring strain, that was actually a week later. So goalies, we tend to think of muscle strains can be a stretch, and we think of goalies doing the splits as